Definition of systemic sclerosis. Chronic inflammatory symmetrical polyarthritis that involve peripheral joints and characterized by skin thickening and systemic inflammation due to deposition of collagen at skin, GI, lungs, kidneys. Skin involvement in diffuse and limited systemic sclerosis. Diffuse, all part of body. Limited, distal to elbow and face. Complication of diffuse systemic sclerosis. ILD. Complication of limited systemic sclerosis. Pulmonary hypertension. Main pathology in diffuse and limited systemic sclerosis. Diffuse, fibrosis mainly plus vasculopathy. Limited, vasculopathy mainly. Scleroderma mimics what conditions? 1. Eosinophilic fasciitis plus groove sign. 2. Nephrogenic system fibrosis. 3. Drug-induced after gadolinium contrast. Etiology, age, male-female ratio of systemic sclerosis. Orphan disease with unknown cause. 35 to 50 year. 5. 1F, M. HLA associated with systemic sclerosis. HLA Dr. B1, 11. Dr. 5. Viruses associated with systemic sclerosis. EBV, CMV, parvovirus B19. What are agents which are associated with agent-induced scleroderma? Silica, max, vinyl chloride, bleomycin, pentazocine, L-tryptophan contaminated. What's VES? Very early systemic sclerosis. 2/3 road cases of VES proceed to SSC in 3 to 5 YRS. Clinical features of VES. Triad, Raynaud phenomenon, ANA positive, nail fold capillaroscopy. What's Raynaud phenomenon? Episodic vasoconstriction in response to stimuli like cold stress and vibration. Clinical manifestations of Raynaud phenomenon. Pallor, cyanosis, redness on rewarming, pain, tightness of digits, puffy hand. Difference between Raynaud's disease and phenomenon. Raynaud disease, it's primary Raynaud. Raynaud phenomenon, it's when Raynaud feature is seen secondary to other diseases. Age, ANA, and familial history association for primary and secondary Raynaud's phenomenon. Primary young female, ANA negative, family history positive. Secondary, middle-age female, ANA positive, family history negative. Symptom for primary and secondary Raynaud's phenomenon. Primary, self-limiting, symmetrical. Secondary, severe, critical limb ischemia, ulcer, gangrene. Secondary Raynaud's is associated with what diseases? Systemic sclerosis, Sjogren, mixed CT disease, inflammatory muscle disease. Finding in nail capillaroscopy for primary and secondary Raynaud's phenomenon. Primary, normal. Secondary, dropout of capillaries, dilated, tortuous, microhemorrhages in capillaries. ANA pattern seen in limited SSC and diffuse SSC. Limited, centromere. Diffuse, fine speckled. Antibody seen in limited SSC and diffuse SSC. Limited, anti-centromere. Diffuse, antitopoisomerase, anti-RNA polymerase 3. Raynaud phenomenon in limited SSC and diffuse SSC. Limited, long-standing and severe. Diffuse, short-lasting and less severe. Limited SSC is associated with what syndrome? Crest syndrome, C. calcinosis cutis, R. Raynaud's, E. esophagitis, S. sclerodactyla, T. telangiectasia. What features are against limited SSC? Extensive fibrosis, ILD, cardiac involvement, renal involvement. Skin manifestation of diffuse SSC. Face salt and pepper appearance. Face tightening, pursed lip, puckered mouth, mask facies, dry tight, thick skin, hair loss, intense itching. Skin thickening in diffuse SSC is unilateral or bilateral and symmetrical or asymmetric. Bilateral symmetrical. What subtype of SSC where there are no skin changes? Sign SSC. Most common cause of death in SSC. Interstitial lung disease. Joint manifestation seen in limited SSC. Acral osteolysis, falling off of fingers. Diffuse severe Raynaud. Joint manifestation seen in diffuse SSC. Arthritis and myositis. Upper GI endoscopy finding in SSC. Watermelon stomach gastric antral vascular ectasia gave in diffuse SSC. Tendon friction rubs are associated with which type of SSC? Diffuse. Scleroderma renal crisis features. Affects small vessels in kidneys. Thrombotic microangiopathy leading to accelerated hypertension plus renal failure. MAHA plus thrombocytopenia. Treatment of scleroderma renal crisis. ACE inhibitors. Phases of SSC. Edematous phase, more in diffuse. Fibrotic phase. What kind of edema is seen in SSC? Non-pitting. Investigations in SSC. 1. HRCT IOC. 2. PFT for ILD, decreased DLCO, FRC. 3. X-ray. X-ray finding in SSC. Bilateral basal subpleural reticular infiltrate. HRCT patterns which are found in SSC. NSIP greater than UIP. NSIP pattern on HRCT, features. No destruction of lung parenchyma. Ground glass opacities. Treatment, steroid. UIP pattern on HRCT, features. Destruction of lung parenchyma, honeycombing, cystic changes, traction bronchiectasis. Treatment of SSC. First line CCB plus sildenafil. Second line, bosentan endothelin antagonist. Treatment for skin manifestation of SSC. MMF mycophenolate mofetil. Treatment for ILD manifestation due to SSC. Nintedanib plus MMF. Non-responsive to steroids. Treatment for joint plus muscle involved in SSC. Steroid plus methotrexate.